Peace, peace. Welcome to the YouTube live book reading of Clinical Application of Respiratory Care by Barry A. Shapiro, Ronald A. Harrison, and Carole A. Trout. And I'm your moderator and narrator, Uriel. Welcome. Peace, YouTube. Happy soul return to me, your moderator and narrator. We pick up at page 143. Welcome, everyone, to my soul return edition of live book reading from the light here in LA. Thank you so much for being here. This is episode 22 of this book. So, clinical guidelines, page 143. Here we go. Following the clinical guidelines for administration of oxygen therapy. Peace, YouTube. Highest heart love. Welcome. Welcome. Following the decision that a patient needs oxygen therapy, the approach for determining the appropriate system depends primarily upon answering the following two questions. 1. Is a low flow system adequate, or must a high flow system be employed? And 2. Will the needs be primarily for low concentration or high concentration oxygen? Low concentration oxygen is an FiO2 below 35%. High concentrations of oxygen are those above 50%. 35 to 50% are considered moderate concentrations. Low flow delivery systems are better tolerated by the patient and the more convenient for the therapist to set up and deliver. Therefore, it follows that whenever a low flow system is adequate, it should be employed. Adequacy is determined by whether or not the system will provide consistent and predictable inspired atmospheres of oxygen. Table 7.3 outlines the general criteria for evaluating whether a low flow system, will be adequate. In general, one may say that a low flow system is reasonably normal ventilatory pattern and minute volume. System is adequate when a patient is stabilized clinically and has a reasonably normal ventilatory pattern and minute volume. It has been our experience that the adult patient whose tidal volume is between 300 milliliters and 700 milliliters, whose ventilatory rate is below 25 times per minute, and whose ventilatory pattern is regular, will receive consistent and predictable FiO2s on a low flow oxygen system. A high flow system should be used if any one of these three criteria are not met. And here we go, table 7.3, criteria for use of low flow systems. Low flow system is adequate if A, tidal volume is 300 milliliters to 700 milliliters, and B, ventilatory rate below 25 per minute. C, ventilatory pattern regular and consistent. So this is table 7-3. Thank you for reading with us. Thank you for the likes and subs. We are pushing towards 500 reading books here live on YouTube. This is clinical application of respiratory care. Thank you so much for reading with us and being with us. The peaceful part of YouTube where we read books and learn from masters. All right, here we go. If it is anticipated that the oxygen therapy will have an effect on the ventilatory pattern, a high flow system should be utilized so that the change in ventilatory pattern will not change in the inspired oxygen concentration. In our experience, over 75% of patients requiring oxygen therapy are appropriately treated with low flow systems. Following the guidelines, we can choose an appropriate appliance that can deliver a consistent oxygen concentration in the range of desired FiO2. Most important, we will be capable of increasing or decreasing the inspired oxygen concentration within reasonably predictable limits. It must be clearly understood that even though the term low flow oxygen is considered to mean low concentration oxygen, yes, delivered via low oxygen flow rates through a nasal cannula, this may not be as low an oxygen concentration as believed. If the patient has a very shallow tidal volume or an unusually slow ventilatory rate, the inspired oxygen concentrations may be much higher than anticipated. This discussion has been purposely conceptual rather than technical, primarily because the field of respiratory therapy is advancing so quickly that any considerations of specific equipment would be quickly outmoded, and unsatisfactory for many regions of the country. For specifics, for specifics concerning various types of apparatus, the reader is referred to various technical respiratory therapy textbooks and to recent journal publications. In the middle of page 144, peace, highest heart, love. Thank you so much for reading with us. Peace, happy Monday. Yes, we are here. We made it. I started this one at my birth time, 3:26 a.m. Highest heart love. Thank you for being here with me. Thank you for the likes and subs. We're pushing towards 500 reading books. Yes, Coco Elo Shoon. Peace, we made it. um, 16,802. Evaluation of oxygen therapy. Evaluation of adequacy and effectiveness of oxygen therapy is simple and direct when cardiopulmonary homeostasis is understood. This evaluation is primarily concerned with two factors. One, physical examination of the cardiopulmonary system, and two, the measurement of arterial blood gases. Physical examination of the cardiopulmonary system. The goal of oxygen therapy is usually to provide adequate tissue oxygenation while minimizing cardiopulmonary work. Therefore, the evaluation of oxygen therapy must include a basic evaluation of the cardiovascular and ventilatory status. Thank you so much. Oh, peace, Sandra. Highest heart love. Thank you so much. Hello, beautiful. And peace, Coco Elo Shoon. Grand Rising. It's a special day. Happy solar return, Uriel. Thank you so much. Much love. I feel the love. I'm so honored to all of you being here and reading books with us. This is my dream come true. That's why I was like, I have to on my solar return to make sure I come read to you. This is important to me. Thank you so much for being here and reading books with us. I'm so honored. Cardiovascular vital signs are composed of blood pressure, pulse, and perfusion state. It is always desirable to have a baseline with which to compare, but this is not always possible. Certainly, these measurements and observations should be made each time an evaluation is undertaken. Systolic and diastolic blood pressure pulse rate counted for full minute, 1 full minute. And arrhythmias should be noted. The perfusion state is best approximated by noting the patient's skin color, texture, and capillary refill. Skin that is warm and dry is being adequately perfused. Urine output and the level of consciousness are good indications of overall perfusion. A patient who has an intact sensorium is a patient who probably has adequate brain tissue perfusion. A patient who is confused and agitated should be assumed to have inadequate cerebral oxygenation until proven otherwise. That's key, very key. Ding! Right? The skin color and if they're confused or not. Very powerful observation. The ventilatory system is observed and evaluated by measurements of tidal volume, ventilatory rate, and an assessment of the work of breathing. Perhaps the most common mistake in clinical medicine is to assume that the tidal volume can be adequately evaluated by observation alone. Experience has taught that the clinician is far more aware of degrees of stress in breathing than the volume of breathing. It is imperative to measure the tidal volume whenever oxygen therapy is critical. The ventilatory rate should be counted for 1 full minute. Irregularities in rate or tidal volumes must be noted. There is no single factor that can affect oxygen therapy to a greater extent than the ventilatory pattern. The work of breathing can be generally assessed by noting the muscular work involved with the ventilatory cycle, especially the use of accessory muscles. In the conscious patient, it is always helpful to investigate the degree of dyspnea. One should never discount or underestimate the meaning when the patient tells you that it is easier or harder to breathe. The most sensitive indicator of a recent change in the state of a patient's work of breathing is his or her own subjective complaint of dyspnea. Peace, peace. Thank you so much for being here on this Happy Soul Return edition. Much honor. Thank you for being here and honoring my solar return. 46, 18,000, or 16,802. Peace, Sandra Willoughby. Highest heart love. Thank you so much for liking and subscribing. We have so much appreciation for all the book readers and book lovers community. Thank you so much. Peace, peace, Ham. Oh, highest heart love, Ham came in. We're reading Clinical Application of Respiratory Care, MCAT medical books for the next generation. We want to make sure that they're ready for helping to heal the world and become a light worker, nurse and all different types of respiratory practitioners, breath technicians. We just honor you all so much. Thank you. Arterial blood gas measurements. Down at the bottom of page 145. Arterial blood gas measurements are an essential part of the evaluation of oxygen therapy and must be accomplished as frequently as deemed necessary by the clinical situation. It is not only the PO2 measurement that is significant in the assessment of oxygen therapy. The ventilatory state, hemoglobin content, and acid base state must also be evaluated. Only in the perspective of these factors can the meaningful appraisal of arterial PO2 be accomplished. Recent cardiopulmonary measurements and observations should accompany each blood gas sample. To illustrate the principles of oxygen therapy evaluation, let us study an illustrative example. Peace, peace. Thank you for reading with us. 35-year-old man with severe bilateral pneumonia. This shunting and venous admixture disease produces an arterial hypoxemia to which both the healthy cardiovascular system and the diseased pulmonary system respond. We would predict that the cardiopulmonary system would work hard enough to maintain an arterial oxygen tension at which the peripheral chemoreceptors would be minimally stimulated, approximately 60 millimeters Hg. Thank you so much for the likes and subs. My highest heart love. This is so much love. Oh, highest appreciation and heart love. Man, so honored, so honored. When an increased oxygen atmosphere is breathed, the alveolar oxygen tensions are increased. This means that the heart and the ventilatory muscles can do less work while the arterial oxygen tension is maintained so that tissues are adequately oxygenated. The organism will not preferentially increase the arterial oxygen tension in ventilatory work is great or if myocardial work is significantly increased. In essence, the patient who is alveolar hyperventilating decreased PCO2 in response to hypoxemia will preferentially decrease ventilatory and not increase arterial oxygen tensions significantly until any increased cardiopulmonary work is relieved. Here are the blood gas measurements and the vital signs of this 35-year-old male with bilateral pneumonia. Breathing room air. All right, pH is 7.52. The BP is 150 over 80. The PCO2 is 28 millimeters Hg. The P is 130 over minute, 1 minute. And the PO2 is 60 millimeters Hg, and the RR is 35 over 35 minute per minute. Hemoglobin content is 50 GMs percent, 50 grams percent. 15. Physical examination shows the patient to be sweating, anxious, and complaining of difficulty in breathing. Note the elevated systolic blood pressure. That's right. The tachycardia, rapid pulse, and the tachypnea, rapid breathing. His or, his or her arterial blood gases reveal an acute alveolar hyperventilation, acute respiratory alkalosis, and with mild arterial hypoxemia. The patient was given approximately 40 to 50% oxygen. 30 minutes later, the patient was comfortable and had no subjective complaints. No treatment was given other than oxygen therapy. The arterial blood gas measurements now are pH is 7.45 and the BP is 120 over 80. The PCO2 is 35 millimeters Hg and the P is 100 over 1 minute. And the PO2 is 70 millimeters Hg and the RR is 22 over a minute. His blood pressure is normal, and the tachycardia and the tachypnea are significantly decreased. There is a marked decrease in alveolar ventilation and a small increase in arterial oxygen tension. It must be appreciated that the most striking changes caused by oxygen therapy are the decreases in ventilatory and myocardial work. The need for oxygen therapy cannot be appreciated if one judges the need solely by the arterial oxygen tension. The value of oxygen therapy is obvious when one understands that the original purpose of delivering oxygen to this patient was to support the cardiovascular and ventilatory systems primarily by decreasing their need to do increased work. In other words, the oxygen therapy was not only used to treat the hypoxemia, just as important, it was used to manipulate the cardiopulmonary compensatory status so that both the work of breathing and the myocardial work could be decreased, while a satisfactory tissue oxygenation state was maintained. And we'll pause right here. Page 147 of Chapter 7, Oxygen Therapy. Highest heart love. Thank you so much for being here and celebrating this wonderful, wonderful Monday with me. Highest heart love. We made it to 46. Yes. Peace to all my family and friends. Thank you so much for all the beautiful donations sent to PayPal. Man, highest heart love. Thank you, Lewis Deans. Thank you so much, Tyron. Oh, man, I love you so much, Ty. Thank you to all my friends and family. Thank you for reading with me. Clinical Application of Respiratory Care by Barry A. Shapiro, Ronald A. Harrison, and Carole A. Trout. When we reconvene, we will finish out with Chapter 7. Thank you so much for all your prayers and gifts. My dreams are coming true. Reading books to you live from the light here in LA. We had a beautiful, beautiful holiday. Well, my holiday party yesterday was wonderful. We went bowling and it was just so lovely. It was such a fun time. And yeah, I bowled pretty well for not bowling for a couple years. I have to be honest. I mean, I went out of the 10 frames. I got a spare on 7 of them and a strike on one. So it's cool. Hi, it's Heart Love. Thank you for reading with me. We are going to give honor to all the August 25th. Thank you so much. Hi, it's Heart Love and Honor. I love you. Troy, I love you. Hi, it's Heart Love. Troy. Troy Young. Thank you so much, Mom and Dad. I love you so much. All you've done for me, bringing me into this world, the beautiful, safe environment, wonderful, flawless genetics. That's what we do. Keep climbing. Mm, I love you. Thank you so much for reading with us. I'm so grateful and thankful for all that I have now and all that is coming to me. So grateful and thankful. Thank you so much. Oh man, I love you. Thank you, Maddie. Hi, it's Heart Love. Peace, peace. Thank you. We are reading Clinical Application of Respiratory Care, giving people MCAT material for their benefit so we can help heal themselves and we can heal others. That's what it's all about, mastering thyself. I honor you. Thank you so much for everything that you've done for us. I love you. I love you. I love you. I love you. Thank you so much for the likes and subs. Pushing towards 500 in this peaceful place in YouTube where we read books and learn from masters. I want you to have a wonderful day. I will see you soon. Peace, peace. I love you, Isis.